Welcome, everyone. We'll get started in just a minute. In the meantime, I will go over a few housekeeping items. If you need captions, click on the Show Captions button on the bottom of your screen. You can drag the box where the captions appear and position them anywhere on the screen. Click on the Q&A button at the bottom of your screen to submit questions and comments to the speakers. We will answer as many as possible within the allotted Q&A time, and whenever possible, speakers will directly answer questions in the chat. We will share the recording and the transcript after the webinar with those who are registered. We also have a YouTube channel as well as a webinar page on our website where you can find previous recordings, and we'll add this one as well. So welcome everyone, and thank you for joining this Brain Inflammation Collaborative webinar. I'm Christy Jagfeld, one of the co-founders of the Brain Inflammation Collaborative. We have a lot of great information and speakers to get through today, so I'll keep this brief. I first became a patient advocate after my youngest was diagnosed with several chronic illnesses in 2012. I co-founded the Brain Inflammation Collaborative because although I loved all of the advocacy work that I was already doing, I was frustrated with the lack of collaboration between organizations and the responses from people on, in general, how little they knew about chronic illness. I also knew there were too many barriers to research, and the infection-driven illness-based in the infection-driven illness-based progress wasn't happening quickly enough. Today, we're going to be talking about our mood and behavior study, which explores how the brain and body interact to influence emotions, focus, and daily life, and how this data will help clarify the biological and behavioral pathways that link neuroimmune activity to emotional regulation and day-to-day functioning. We also have a caregiver who will talk about how hard it is to navigate this space as a parent. We can talk about this in casual terms, but at the end of the day, it's really hard. Now I'm excited to introduce our guest speakers today, Melanie Helvig, Dr. Megan Fitzgerald, and Gwen Candula. We'll first hear from Melanie Helvig, who is a former clinical research associate with the Brain Inflammation Collaborative. Melanie is a third-year doctoral candidate of clinical psychology at the George Washington University. She holds a master's degree in forensic psychology, also from George Washington University, and a bachelor's degree in psychology and legal studies from the University of Wisconsin-Madison. Melanie has previously volunteered with the National Alliance on Mental Illness, providing resources and support to individuals and families through their helpline, and has also worked in case management with the nonprofit aiding in the reduction of homelessness. She currently provides therapy and psychological assessment services under supervision to children and adults in an inpatient setting, and she approaches care with a holistic and social justice orientation. Next will be Dr. Megan Fitzgerald. She's the principal investigator and scientific director here at BIC. Dr. Fitzgerald earned her PhD in neuroscience and neurology from Weill Cornell Medical College and completed postdoctoral fellowships at Mount Sinai, Columbia University, and UPenn, focusing on the neurobiology of psychiatric disease and stem cell research. Her work was interrupted in March 2020 by a COVID-19 infection that led to long COVID. Dr. Fitzgerald pivoted her research to study her own illness, learning from her firsthand experience of living with long COVID. She joined the patient-led research collaborative in late 2020 to leverage her scientific background to try to provide insights that would improve the lives and health of other patients. With the Brain Inflammation Collaborative, she aims to explore the connections between inflammation and the mood and neurological symptoms that patients experience, such as brain fog, and to continue to foster collaboration by bridging the gap between patients, clinicians, and scientists. Gwen Candula will be our final presenter. Gwen is a member of our board of directors. She's also an audiologist and co-founder of Advent, a multi-state medical practice dedicated to improving patient health with a focus on upper airway breathing and simple office-based solutions. For more than 2 decades, she has guided Advent's growth, building patient-centered framework while fostering a compassionate people-focused culture. Her commitment to the Brain Inflammation Collaborative is deeply personal. After seeing how PANDAS affected her own family, Gwen is devoted to advancing awareness, research, and access to care for families navigating those complex conditions. In addition to her clinical expertise, Gwen holds an MBA, which has helped her bridge the worlds of medicine and business. With regard to disclosures, the presenters have no conflicts of interest, and thank you to our speakers and audience members for participating today. Thank you so much for joining us, Dr. Fitzgerald, Gwen, and Melanie. I'll now hand it over to Melanie Helvig.
Hi, everyone. I hope you can see me okay. Thanks, Christy, for the introduction. So I'm going to be starting us off today to share an overview of what the Mood and Behavioral Questionnaire is, why it was created, our goals for the questionnaire, and also the development process that we went through to make those goals a reality. So you can go to the next slide. Thank you. So what is it? This questionnaire was designed to capture emotional, cognitive, and behavioral experiences of people experiencing neuroimmune conditions. It launched in the Unhide platform earlier this year as part of a larger effort to learn more about neuroimmune conditions, their presentations to hopefully improve our understanding of the different ways that these conditions can present and improve treatment outcomes. So under this umbrella of experiences, emotional, cognitive, and behavioral, we're really looking at some of the specific symptoms or experiences that are captured here in this list, to include a few. So obsessions and compulsions, eating behaviors, mood experiences from sadness, anxiety to anger, thinking difficulties, so difficulties with cognition, sensory experiences, headaches, migraines, and sleep disturbances. Again, just to name a few of the things that we were aiming to capture. And as I'll talk about in a moment in regards to developing the questionnaire, the goal was to create something that was broad enough to capture a wide range of symptoms and concerns that might be present across the different conditions that were backed both by research and reports from real patients and families. So the questions ask individuals to look back over the past month and rate the frequency of these experiences on a scale from not at all to daily. You can go to the next slide, please. Thanks. So the questionnaire has 3 forms or versions that we tailored to who is reporting to ensure we could capture data from patients of all ages, as well as parents or caregivers when applicable. So all 3 forms cover the same symptoms with language tailored to what would be most accessible for that group. So the form for children ages 7 to 12 is written in kid-friendly language, short and simple questions that maintain the essence of the symptom while making it reachable. For example, rather than asking kids 12 and under if they're experiencing migraines, we boil that down a little bit and ask them if they're having headaches that were so bad that they needed to lie down and rest in a quiet place. So tailoring that a bit to make sure that it's understandable to them and that they can communicate what is true for them in the best way possible. And then the form for teens through adults, we're able to be a little bit more detailed, focused on the personal experiences still, but at times using clearer language, adapting then that language from children through teens and adults so that we're capturing the same symptoms, but just in slightly different ways. And then for parents or caregivers, this form was really important for us to supplement the information that children are providing as they have unique insight into their child's symptoms and daily functioning. The language then tailored at times here to be more centered on observable symptoms, especially when it comes to symptoms that the child may not be voicing or have the language for quite yet, but are emerging in observable behavioral ways. Next slide, please. I thought it would be helpful to get a look at what the questionnaire looks like within the Unhide platform. So you can see on the leftmost image, we're outlining for individuals right off the bat the purpose of this particular questionnaire. why it's helpful, and the estimated time burden. We wanted to be really upfront that the reason that this is helpful is that it's going to help researchers understand the different ways that the body and brain might be influencing mood and behavior, and holding in mind the unfortunate reality that so often mood and behavioral symptoms that result from these conditions can be overly psychologized. We wanted to be upfront with that. So the questions that emerge for people clicking into the survey are being able to kind of be addressed right away and hopefully assuage some of those fears. And then in the middle, you can see an example of what a question might look like, the usability of the platform, allowing it to be clickable and hopefully easy to use. So you're seeing here an example of a question about obsessions tailored to the adult, 13 and up to adult age range. And also to that point of making things accessible and easy to use, I just wanted to highlight that we offer kind of a check-in partway through, reminding patients that they're able to pause and return back to the survey at any given time, along with our goal to kind of reduce the burden to the patient populations and the people being so gracious with their time to participate in this and further the research. Okay, so now with a baseline understanding of what it looks like, what it is, I wanted to zoom out a little bit and talk about why it's important and what the need for a questionnaire like this is. Because there are many questionnaires that assess different aspects of mood and behavior and cognition. However, many of the existing questionnaires do focus narrowly on just one aspect of mental health. So that can look like questionnaires that are specific to symptoms of OCD, symptoms of depression, and it can also look like questionnaires that have been created in the research tailored to a specific neuroimmune illness, like the PANSS rating scale. What we've seen is that IACCs and neuroimmune illnesses often are presenting with a complex mix of the psychiatric and behavioral symptoms that are, again, a result of the illness itself and can be understood in the context of the impact that inflammation has on the brain, which Megan will outline a little bit more in detail in a bit. But the goal of the survey then is for us to better understand the mood and behavioral correlates of neuroimmune illnesses and IACCs to improve outcomes. Next slide. I wanted to highlight a quote here from Denise Calaprice, who was one of the co-founders of the Brain Inflammation Collaborative and a senior program advisor. So she points out here that clinical research on neuroimmune illnesses across the board is hindered by this lack of concise measurement tools that do capture the full spectrum or full mix of symptoms that we might see in different presentations. So like I noted, many of the existing questionnaires that focus narrowly on one aspect of mental health or narrowly on one specific patient population could be limiting perhaps a piece of the symptoms that might be helpful to understand the clinical picture, and also the overlap that might be emerging between these conditions due to the similar processes happening in the inflammation in the brain. So this poses a problem in clinical research due to the potential underestimating of the burden of these conditions on patients, and also obscuring the treatment effects. So if we're not measuring all of the symptoms that are present, it makes it difficult then to understand how efficacious the treatments are that we are looking into. And so developing and testing this measurement is hopefully tailoring an experience, a questionnaire to the mood and behavioral symptoms that we found are associated with neuroimmune conditions and allowing us to address this concern. Next slide. Okay, so following these concerns, our goals were to fill the gap, develop a brief survey that reduces burden on participants, but is also has some clarity and accuracy in the questions. Because the questionnaire asks patients to look back over the past month in reporting, it allows the opportunity to present the form at reoccurring intervals with the hope of understanding the presence of these symptoms or absence of these symptoms, perhaps when individuals are in a flare and when they are not. But to feel comfortable doing so, presenting this multiple times to the same participants, we wanted to ensure that we were centering patient needs reducing the burden and reducing the amount of time they're spending in their participating in research. In addition, so many available questionnaires might not fully represent the unique concerns of people managing these conditions. So clarity and accuracy in questions, specifically in how real people are describing their symptoms, was important. This also includes accuracy then across the different forms, the ability to collect data from multiple parties, and we wanted to include as many problems and concerns while keeping things brief, but allowing us to gather more data about how symptoms emerge, both in the research that we're seeing, but also in the actual lived experience. And then finally, we maintained this overarching goal of centering patient and caregiver feedback, including regarding what symptoms we are actually asking about, how they're described, and even down to the general feeling that participants are walking away from the survey holding on to was something that we centered as one of our primary goals. So with that, on the next slide, we'll see here, I outlined our stages of development, which it's condensed to these 5 steps, but was really quite the lengthy process because of how much this really meant to us in getting it right. So we started off by reviewing the existing questionnaires and surveys that are already out there, the symptom-specific ones, such as anxiety questionnaires like the GAD-7, questionnaires for depression, sleep, cognitive symptoms, and also reviewing surveys like the PANSS rating scale, assessing the ways in which we're framing these symptoms in a way that's already been proven to be really helpful. So pulling questions from these different questionnaires, getting at the root of the nature of the symptoms so that we can ask as few questions as possible while having still a really meaningful and comprehensive assessment of what might be going on. We also then drew upon symptoms reported in the research. Some of these studies that we looked at include those by the Recover Initiative, investigating symptoms associated with long COVID. Megan drew on some of her expertise in this phase, having been involved in some of these projects. So really learning a bit more about the neuropsychiatric and neurological symptoms associated with COVID infection and long COVID. Some of these things included anxiety, OCD, ADHD and autism in children, and also an increased risk of depression and thoughts of suicide in teenagers and adults. So in addition to this, we then did a version comparison for consistency across raters. This really looked like breaking down each symptom with its 3 versions of questions and making sure that they were both accurate, similar enough so we knew we were capturing the same construct, the same symptom, but still tailoring it so that it's reachable and adaptable for each person. After completing steps 1 through 3, we have a questionnaire. We've pulled questions together. We have a sense of the direction we're going, what we'd like to include, but we went through a very extensive user testing process to get feedback and center that goal of involving patients in our process. Megan had noted that this was one of the more extensive user testing and revision processes that she had been involved in, and we really took our time in this step. So we asked patients to complete the survey and offer feedback, and we're able to have both child and caregiver dyads and adults complete this, primarily consisting of long COVID patients and PANSS patients. So with this feedback, extensive revisions, additions, and rewrites were made. This included splitting some questions into 2 separate ones. For example, in assessing depressed mood, we isolated feelings of sadness from decreased enjoyment or anhedonia to make sure that these things that can co-occur are also assessed in isolation to get a full understanding of what that might look like for folks. We reduced some ambiguity and interpretation, taking into account what patients were reporting was kind of confusing or unclear, where the phrasing could be changed a little bit, clarifying what kind of severity of a symptom that we're looking for. So individuals know how to differentiate between typical day-to-day fluctuations in mood or behavior from those that are impactful to functioning. We also added in an open-ended question at the end, which was highly requested as a way to kind of offer a narrative experience if participants are willing to take that extra time to do so, and maybe highlight some symptoms that were not found in previous questionnaires or the research, but are impacting this particular individual and feels important to share. And I'll note too, while there were extensive revisions, lots of tweaking, we also got very positive feedback from patients that it was pretty easy to understand, a good length, the topics were comprehensive. And so at the end of this lengthy process, we've come away with this measure that's broad yet concise, and now a very important measurement in the Unhide platform to help us get an understanding of what mood and behavioral symptoms are and are not present for people managing these conditions, and hoping to get more data as we go forward. So with that, I'm pleased to hand things over to Dr. Megan Fitzgerald of Brain Inflammation Collaborative. She's going to share a little bit more about how we're working to address patient concerns and what we're seeing in the research before diving into some of the data we have already.
Thank you so much, Melanie. Just give me 1 second. I'm going to share my screen. Okay, there we go. So I'm going to be talking about some of the actual data that we're pulling from this survey already, and how we're going to use the Mood and Behavioral Questionnaire, which I do abbreviate on many of my slides as the MBQ. As much as I hate acronyms, it just gives me a bit more room. So using the Mood and Behavioral Questionnaire to go beyond these single diagnoses and to better understand the symptom landscape of infection-associated chronic conditions. So neurological and neuropsychiatric conditions can be related to neuroinflammation in infection-associated chronic conditions and neuroimmune diseases. When we say infection-associated chronic conditions, this can mean conditions like PANS and PANDAS, as Melanie had mentioned, long COVID, ME, which is also known as ME/CFS or myalgic encephalomyelitis, Lyme disease, just to name a few. Neuroimmune diseases might include autoimmune diseases, or especially conditions like multiple sclerosis or MS. These neurological and neuropsychiatric symptoms at the onset of these conditions, particularly ICCs, can arise very suddenly and simultaneously with many other physical symptoms. I think one of the frustrating things for patients is that these new onset psychiatric and neurological complaints are not always being seen as symptoms of their health condition, but they're being treated as though the extreme and disabling physical health conditions they're experiencing are manifestations of mental health problems, when the reverse is true, if that's clear. And these can be caused by these symptoms, the neuropsychiatric and neurological symptoms can be caused by a number of known pathways that occur within the brain, such as mast cell activation. Histamine and cytokine production from mast cells can trigger microglia activation and microglia proliferation, so directly influencing neuroinflammation in a lot of these symptoms. There's dysfunction of the blood-brain barrier that's been demonstrated in long COVID patients with brain fog, as well as persistent immune activation, which has been demonstrated both in infection-associated chronic conditions as well as in multiple sclerosis. And the autoimmunity that's shown in infection-associated chronic conditions like long COVID has been shown to correlate with neuropsychiatric symptoms, some of which are listed in the word cloud on the screen, like fatigue, anxiety, depression, brain fog, vertigo, migraines, dizziness, and sleep disorders. I want to highlight PANS and PANDAS as a canonical model of infection-triggered neuropsychiatric illnesses. PANS stands for Pediatric Acute Neuropsychiatric Syndrome, for those who are not familiar with the disease or the diagnosis, and PANDAS is a subset of PANS. It's specifically triggered by strep throat, whereas PANS encompasses a broader range of infectious and immune triggers, one of which includes COVID. It's characterized by a very sudden, severe onset of OCD and or restrictive eating in children, and that's often accompanied by noticeable changes in mood, behavior, and sensory and motor function. The pathogenesis has been shown to be immune-mediated, likely targeting the basal ganglia, involving autoantibodies, complement activation, and pro-inflammatory cytokine production. So these are all pathways that the immune system is involved in. And it does share mechanistic overlap with conditions like autoimmune encephalitis, as well as post-infectious conditions like long COVID. So PANS and PANDAS really establishes a very clear infection, leads to immune dysregulation, leads to neuropsychiatric symptoms pathway. So it's not the traditional, psychiatric disease, and it can't be treated like by treatments that people would use to treat purely psychiatric disease. Instead, it responds to treatment modalities like IVIG, which is what our last webinar was about. And I think that PANS and PANDAS can really help to provide a framework for understanding and treating neuropsychiatric manifestations across multiple post-infectious conditions, particularly when they're manifesting in children and teenagers, like long COVID and ME in the younger populations. So that said, I do want to address some patient concerns. As Melanie had pointed out, we did have this field where people were able to provide feedback in the survey about other symptoms they might experience, about the survey itself, and some people use that field to express concern about the subject of the survey. And I wanted to highlight 2 quotes so that we can all understand where patients are coming from. One is to be very clear, I'm not exhausted because I'm depressed. I do experience depression because I am always exhausted from CFS, it's ME/CFS, or chronic fatigue syndrome. I want my life back. Another responder wrote, this questionnaire seems to be about mental health when my disabling post-viral sequelae are biological. So I want to reiterate a lot of what Melanie was saying, is that the purpose of the mood and behavioral questionnaire is to study the burden of neuropsychiatric symptoms in people of all ages with different neuroinflammatory conditions, but we're not trying to psychologize any physical symptoms, which has absolutely been done in the past, particularly to people with ME. It's definitely not what we're doing here. And if you're looking at this, you're like, hey, I have ME, I have long COVID, I don't know if I want to take this survey because I don't really think that I have a lot of, mood and behavioral symptoms or sensory sensitivities or problems with sleep or the other things that we're asking about. I want to reiterate that negative data is valuable as well. So if there are people, whether they're healthy controls or people with long COVID or other ME, any other conditions that we have in the platform who don't really have these mood and behavioral symptoms, we want to hear from you as well, so that we can get a really true and holistic portrait of what these diseases look like, including some of the symptoms that have historically been understudied that we're asking about. Another patient concern that was common was patients had concerns that events around the time that they were taking the survey would impact the data. So a number of people wrote that, my pet just died, so I'm feeling really down and blue right now. Or, I've been reading the news a lot. There's a lot going on in the world, and that's impacting my anxiety that I normally don't feel. I want to say, we are addressing that. We do schedule the survey to repeat quarterly. And so that, recent events in your life are not going to bias the overall data from the survey. So I do encourage people to take this if it pops up again in their platform. And finally, I'm going to, before delving into the data itself, I'm going to address how are we delivering this survey? How are we doing this? All the work that BIC is doing, the Brain Inflammation Collaborative is doing, is through our Unhide platform. This platform is an app that can be downloaded, and you can also access it via the web. And it's an online health platform. It can be used to track symptoms, connect wearable devices, download symptom data reports, complete surveys like this one. You can also use it to set pacing notifications, and it can be used to identify patterns in your own health over time. So it spits out a ton of information for you to look at and to track how you're responding to treatments and to share with care providers. And I really encourage anyone who isn't signed up already to please check out our website to see how this platform can help you manage your chronic condition. It also allows participants to connect with researchers and participate directly in research studies like this one that we're talking about today. And it's run by us, the Brain Inflammation Collaborative. It uses My Data Helps as our service provider. And this was formerly known as Solve Together. It was run by Solve ME, another nonprofit. It's free for participants, and your data is never going to be sold or used for advertising purposes. It's never going to be gatekept like it can be for a lot of the for-profit companies who have apps out there. And so the rest of this presentation is going to highlight how we're using some of the data that we're collecting in this platform. So this is who's taken the Mood and Behavioral Questionnaire so far. We only launched the pediatric platform a number of months ago. So the bulk of our participants in Unhide are adults. And I am encouraged that, we do have a fair amount we have 20 people here, 13 parents and guardians, 13 teenagers and 2 children who have taken the pediatric versions or the parent proxy versions of the survey. And we are actively recruiting. I would ask anyone who's looking at this talk to please if you know any children, any families who are coping with this chronic conditions, please let them know about Unhide. We'd love to try to help them and to incorporate them in the data. But for today, because we don't have enough pediatric data to talk about, I'm going to be speaking about this wonderful cohort of 646 adults who have taken this survey. And that will get into it. So the average age of participants who have taken the survey is between 52 and 53 years old. 84% are female at birth. Now that's very representative of who is in our platform, and it's also fairly representative of people who have of a female bias in these sorts of conditions. 91% did identify as white. We are working hard to increase historically marginalized populations in our platform as well, and are eager for partnerships to help do so, because that number, that 91%, is not representative of who is most impacted by these conditions. The median time it took to complete survey was less than 5 minutes. It was only 4 minutes and 23 seconds. And I think, even though it's 47 questions, we were afraid it was going to take a bit longer than this. But I think because we did have such extensive user testing and we really incorporated feedback and plain language feedback into how we're presenting these questions, that it is really quick for participants to get through, which is great. And people who responded had multiple different health conditions and diagnoses. So these are the conditions that adults who have taken the Mood and Behavioral Questionnaire have. The most common diagnosis in the cohort was ME, with over half of responders reporting having ME. Over 40% reported having anxiety. About 34% had long COVID, followed by dysautonomia, POTS, depression, migraines, fibromyalgia, sleep apnea, and IBS. And I want to point out that people may have had multiple of these conditions. They are comorbidities, so these are just the absolute number of diagnoses. It doesn't represent each individual having one diagnosis. So next I'm going to speak about some of the results of the survey and the statistical analysis techniques that we look at to try to figure out what's happening in the data. I'm going to start with cluster analysis on the Mood and Behavioral Questionnaire responses. So if you're someone who tunes into a number of these webinars, whether they're from Brain Inflammation Collaborative or other organizations, you might have seen cluster analysis before. And I just wanted to take a minute to explain what it is and why researchers use it. So cluster analysis is kind of a smart sorting system for different symptoms. If you can imagine, you have a huge pile of puzzle pieces, and in our case, that would be 47 different symptoms that we're asking about. Cluster analysis is kind of like having a sorting machine that can group these puzzle pieces together based on how often they're reporting together. And it uses mathematical algorithms to identify patterns across hundreds of patients who have responded to the survey simultaneously. So in our study, we asked which symptoms tend to occur together in the same patients. And Melanie had pointed out we had 7 symptom clusters that we thought about when we were developing the survey, but I didn't use those to decide in advance which symptoms should go together. I let the data tell me which symptoms needed to go together. And the data did also pick up 7 meaningful symptom clusters. And so over in to the left of the slide here, maybe it's your right. This is anyway, the graph here is a dendrogram. And what you can see here is that the way that the hierarchical clustering groups this data. So this is an illustration of one of the clustering techniques. I actually used 2 of them. The other one is called k-means clustering. These are just different statistical algorithms, and found very similar results using both methodologies. So the reason that this matters is because the Mood and Behavioral Questionnaire asks about 47 different symptoms across many different body systems and domains. So rather than looking at each symptom one by one, which would be completely overwhelming, cluster analysis allows us to discover natural groupings of symptoms that co-occur together in the same people. It reduces complexity. So instead of 47 separate symptoms, we found 7 meaningful clusters, and it lets the data speak. As I said, I didn't assume which symptoms belong together. Patterns emerged from what patients actually reported who took the Mood and Behavioral Questionnaire. And it creates cluster scores, which can give each patient a score for each symptom domain. And so these clusters can help us understand patients' experience a lot more holistically. And instead of asking, do you have fatigue? We can now ask, how severely are your cognitive, physical, mood, and sensory systems affecting you? And gives us a much richer picture of what everyone is going through. So these are our 7 different clusters that came up. In this graph, the different size of each bubble represents the number of symptoms in each cluster. And the clusters that came up, the numbers are arbitrary, and they are assigned by the algorithm itself as it's running. The first cluster was attention and executive function. Cluster 2 is cognitive and physical fatigue, which had 4 symptoms. Cluster 3 was the largest cluster, which I termed PANS-like symptoms, which were really complex, severe behavioral manifestations. Cluster 4 was really interesting because it only had 1 symptom, which was tinnitus. Cluster 5 was mood and emotion. Cluster 6, sleep, which comprised insomnia and interrupted sleep. And cluster 7 emerged to be sensory and somatic symptoms. Now, when we designed this survey, we asked a number of questions. I wanted to highlight in a slide the food issues. And we had designed these questions specifically in a way to determine why changes in eating behaviors were occurring. So the question about food amount changes highlighted in cluster 7 here, which would kind of refers to more physical restrictions on eating, such as those that might be experienced by someone with gastroparesis. And it was intended to segregate conditions like gastroparesis from people who might have neuropsychiatric disorders or neuropsychiatric symptoms that translated to eating behaviors. And so it was really kind of gratifying that these two, that it did cluster separately. What was a little bit more surprising, but also makes sense, is how the sleep symptoms clustered. We had insomnia and interrupted sleep in their own cluster here, whereas nightmares clustered with the PANS-like symptoms, and physical and mental fatigue were in cluster 2. Lastly, tinnitus stood out in a cluster of its own. This is unusual in cluster analysis. So as I said, I had used 2 separate statistical analyses methods, k-means clustering and hierarchical clustering, and both methods found these 7 very similar clusters, not fully identical, but both did have tinnitus in a cluster of its own. And that means that tinnitus might be more likely to occur independently of any of the other symptoms that we evaluated. So this is how this heat map over here on the side represents how severely impacted our cohort was by these different symptoms. The darker colors mean that people were more impacted. So you can see cluster 2 here visually, which represents cognitive and physical fatigue and encompassed the questions asking about brain fog, mental fatigue, learning disabilities, and physical fatigue, was the most severe in our cohort. And this is showing the clustering data, and this is why we're doing clustering. I know on the previous slide, you probably couldn't read all of these individual symptoms, and because it's a lot. And so when we're looking at the cluster, we again see here the mean cluster score of cognitive and physical fatigue is at 2.57. Tinnitus is the second most severely reported at 1.84. And then we have attention and executive function, sleep, mood and emotion, sensory and somatic, and the least frequently reported symptom cluster in our cohort that we currently have in the platform were these PANS-like symptoms, which isn't surprising. PANS was not very prevalent in the diagnoses that were reported by people who took the survey. And I want to explain how these symptom scores were calculated. As Melanie had said, our survey had these responses. It was not at all. And this was in response to how often people had experienced the symptom within the last month. 0 was not at all. 1 was a few days. 2 is more than half the days. 3 is almost every day. 4 is daily. So you can see people are really impacted by cognitive and physical fatigue. That is between more than half the days and almost every day. Tinnitus as well is very impactful, coming in between a few days and more than half the days, similarly for attention and executive function and sleep. So people in our cohort are severely impacted by many of the symptoms that we ask about. Next, I'm going to be comparing the findings from our mood and behavioral questionnaire, our new instrument, to select validated survey instruments that we also have in the Unhide platform. And again, this is part of the Unhide platform's power, because there's not a lot of other ways to, this is a low burden way that we can get all of this data from patients, and they can provide it in a way that is patient friendly, where they're getting a return on their investment by seeing how they're doing. And we can compare our data to these other validated tools that exist within the platform. I want to speak very briefly about the value of using validated survey instruments. People might be like, why do we have to fill these out? Validated survey tools give a common language to compare across populations and different diagnoses. They're reliable and produce consistent results. And this has all been, validated in the scientific and medical literature. They are demonstrated, they have scientific validity. They've been demonstrated to measure the construct that they are intended to measure. They're standardized so that the data can be normalized across populations, clinical settings, and different studies. They're very sensitive, so they can detect clinically meaningful change over time, and they have established cutoff scores that can enable clinical classification and severity stratification. So correlations with validated instruments can confirm that our new mood and behavioral questionnaire measures what we intend to measure and provide it with construct validity. So these are, again, on this side of the graph, these are the most common diagnoses. And we also have the validated instrument scores over here. So you can see fatigue is really impacting our population. And in this graph, these have been normalized to show that the higher the score is here, the worse people are scoring on these validated instruments. We have the fatigue severity scale, measures fatigue, GAD-7, which is measuring anxiety and mood. Karnofsky and FUNCAP are two different measures of functional capacity or functional impairment. So this graph, which looks like a bit like a checkerboard or steps, what this is a heat map. And so the darker the score, the more strongly correlated two different measures are. And to read it, you would look at what's happening on the vertical and horizontal axis, and then where they intersect. So if you look here where my mouse is, you have mood looking at, along this kind of 1.0, that means that they have 100% correlation, which you would expect them to have because it's looking at the same instrument. Sleep cluster correlates with sleep cluster 100%, right? And then in the middle, where you're looking at the different correlations between either different symptom clusters or different instruments, you have different correlative scores. So this is where we're going to see this out. So right away, we can see a good agreement of our mood cluster of symptoms with the GAD-7, which is great because it really validates what the gold standard anxiety measure of the GAD-7 captures. And it strongly validates that our mood cluster in the mood and behavioral survey is capturing. Our fatigue questions really strongly correlate with the fatigue severity scale. Again, validating that cluster. What's clinically interesting as well is that the two functional questionnaires that we have in our platform, the Karnofsky as well as the FunCap, also strongly correlate. And tinnitus, which was our standalone cluster, doesn't really correlate very well with any of the other measures we having, which we are taking, which reinforces its kind of unique standalone nature as a symptom. I thought what was also interesting and important to highlight was that the GAD-7 doesn't align at all with the FunCap or the Karnofsky, almost zero correlation. But our mood and behavioral questionnaire does have more alignment with it, indicating that we are capturing some more of the symptoms that cause functional impairment in people with complex chronic conditions. So this is some of the last data that I'm going to be showing. These are validated instrument scores separated by people who have either physiological conditions alone or physiological conditions with reported psychiatric comorbidities, or if they have psychiatric conditions alone. So the yellow is people with only psychiatric disease, the green is people who have only physiological conditions, and the blue is people with a combined condition. So the just to be clear, the psychiatric conditions that were identified in the respondents from this survey were primarily anxiety, depression, PTSD, and OCD. And physiological conditions were considered everything else. That was reported by responders to the survey. So you can see that in the fatigue severity scale, there's no real significant difference between those with physiological and psychiatric conditions, but it's less fatigue is reported by people with only psychiatric disease. For the GAD-7, there's no differentiation between people with only psychiatric conditions or those with physiological conditions as well, but it's, as expected, it's far less for those who only have physiological disease. The Karnofsky, there's no statistically significant difference between those who have psychiatric comorbidities, but there's, you do see an increased functional capacity in people who only have psychiatric disease, as would be expected. This is mirrored by the FunCap as well. Now, I want to go back to our instrument, and the next slide's going to highlight that, the mood and behavioral questionnaire. This is actually the only questionnaire that we tested that reliably distinguishes between all three different groups. So there is statistical significance between people who have physiological and psychiatric comorbidities, physiological disease only or psychiatric disease only, and it shows the increased symptom burden that those with both psychiatric and physiological disease face. So the mood and behavioral questionnaire does capture what other measures are missing and differentiates physiological, psychiatric, and combined symptom profiles. This is for looking at how this applies to ME/CFS, which again is the most prevalent diagnosis in our sample. These respondents shown here have ME, which is a disabling infection-associated chronic condition for anyone who's not familiar with this condition. And again, it was the most commonly reported condition among respondents. Those who have psychiatric comorbidities and reported having both ME and anxiety, depression, OCD, or PTSD. And you can see here how in every single symptom cluster, except again tinnitus, the mood and behavioral questionnaire captures a higher symptom burden for people who have both the physiologic diagnosis of ME and a psychiatric diagnosis. So just go through our conclusions and future directions. To wrap up and summarize, the Mood and Behavioral Questionnaire captures 7 distinct symptom clusters that cut across diagnostic boundaries. Cognitive and physical fatigue is the most burdensome cluster in our current sample. Psychiatric comorbidities significantly amplify symptom burden across all domains of the Mood and Behavioral Questionnaire, and the Mood and Behavioral Questionnaire is the only instrument that reliably distinguishes patients with physiological, psychiatric, and combined diagnoses. There are strong correlations with validated instruments like the Fatigue Severity Scale, GAD-7, FUNCAP, and Karnofsky, and these support the validity of the Mood and Behavioral Questionnaire, and tinnitus emerges as a unique standalone cluster worthy of further investigation. So for future directions, as I said a couple of times, I'm going to say it again, we really want to expand pediatric participation in the survey and the platform using the parent, proxy, child, and teenage versions that we've developed. In line with that, we'd love to recruit more PANS, PANDAS, and Lyme patients to better capture neuropsychiatric symptom clusters, which have frequently been reported in these conditions. And we'd like to compare those symptom profiles directly between Lyme, PANS, PANDAS, ME, long COVID, and associated conditions like dysautonomia, EDS, MCAS, etc. It would be interesting to investigate tinnitus as an under-recognized but very prevalent symptom, and definitely are conducting longitudinal follow-up to track symptom changes over time. And I just want to emphasize why this work is so important. It's a time when we're all experiencing a lot of survey fatigue, and I think, speaking as a patient myself, what we obviously want are treatments and clinical trials. We want biomarkers so the diagnosis pathway is clearer. But this work is still really important because without biomarkers, standardized self-reports can diagnose and differentiate different related conditions, and they can help to guide treatments. What's more is that if and when, and I hope it's sooner rather than later, if and when biomarkers are discovered, they might not be able to measure treatment responsiveness. So in clinical trials, survey instruments are still going to be necessary to figure out how people are doing in clinical care and clinical trials. And it's really important that we have really good patient-informed instruments so we can know how people are doing. And questionnaires like this, which are low burden on patients, they can enable researchers and clinicians to determine how symptoms manifest differently and change over the lifetime. I want to emphasize again that anyone can take this survey. It's still in development. Healthy people, people with multiple chronic conditions, people who have psychiatric disease, people who do not, anyone is welcome to take this survey. And I want to finalize with a thank you to all these participants who have taken the survey in Unhide. As always, if you have any questions, concerns, comments, we love to hear feedback. So please reach out to us. It's help@braininflammationcollaborative.org. We always check that. You can reach out to us through the platform if you'd like as well. I'm going to hand this off now to Gwen, who's going to talk about her real-world experience with the sudden emergence of many of the symptoms that we ask about in the Mood and Behavioral Questionnaire in the context of PANS and PANDAS and how they directly impacted her family. So thank you so much.
All right. Hi, guys. Can you hear me? Just want to make sure I'm showing up. We can go ahead to the next slide. All right, there we are. All right, so this is my first time talking about PANDAS for a group. So please bear with me as it's such, anybody who's going through it, you know just how personal it can be for what it does to your family. But thank you, Megan and Melanie, for that. And I'm just so grateful for the work that Vic is doing and that you guys are doing to help families with this and to help learn more about it as time goes on. So let me start here. This is a picture of my family in 2012. And this is one of the last pictures that we had before our life got kind of turned upside down. So we've got myself and my husband. We have a little puppy here. This is my husband, Mothin. We have a medical practice. He's an ENT, and I'm an audiologist. And we had been working together for probably about 8 years at this point with just a little mom and pop shop. We've got our daughter, Mia, on the left, Lola, a little baby here in the middle, and then our son, Cole, who is he's our middle child. And so this is the last picture we have before our life really got turned on its head. Mia, when she was about 9, so back in 2012, had a real high fever and was basically a cold and a fever. And I think it got to like 104. And we had gotten it down with, Tylenol, ibuprofen. But after that, she was a different kid, completely different. And it's crazy how fast these kids change with this. So we went, it took us a while to really realize that this wasn't going away, that I thought she was just extra clingy. But that was just the start of it. So she went through this in 2012. We started with it, and gosh, what really changed, your life sort of stops. She couldn't go to school anymore. She couldn't sleep by herself. She couldn't be in a room by herself. She just, like, all those symptoms that Megan had listed before. It was crazy to see, or the list, because at some point everybody's had them in my family, at least of the three kids. And I think they've all had most of them at one point or the other. So anyway, she was the one we started with, and it took us a long, long time to get her diagnosed officially. With my husband being ENT, he was able to use, I think, the correct medical terminology to look up what she had going on, and he thought it was Pandis right from the get-go. You guys, even at that, so he's a physician. We worked in a hospital. His entire family is physicians, married to physicians, parents are physicians, all their friends are physicians. We have all the access and everything available at our fingertips. It took us a year to find a doctor who would actually believe Pandis was real and this was a real thing that she had going on. So I can't imagine what it's like for, just out there. I just realize how hard it is. And I'm hoping, nowadays we're here about 14 years later. I hope it's easier, but I still hear from a lot of families, it's still just as hard as it was for us back then. People really don't know what to do. So if you want to go to the next slide. So I just want to show you here, this is my youngest daughter, Lola. This was her when we started Pandis with Mia. And this was her last summer. And what we didn't know was here she has Pandis again. And we took us a while to realize that, but I'll get to that. So if we look just in my family with my three kids and their different times having this, the different symptoms that they've had, there was all like maybe a similarity with like this level of anxiety / separation anxiety, maybe some OCD, but like when my son got it a few years after my oldest daughter, his was more tics and like these teenage boys, they're all like elbows and like knees, and they're sort of growing into their body. And he just wasn't moving right. But I thought for a while, maybe it was just him growing. And I don't know, you see awkward boys as they're getting taller and stuff, but it took us a while. He ended up with a diagnosed strep infection. And with that, you could actually hear Pandis in his voice. And that's when he was able or wasn't able to go to school anymore. So for him, it looked different than with the first. And then by the time my third got it, oh my gosh, hers, we think it was triggered from maybe a flu shot. She had been at the pediatrician's, and then about a week later, we noticed she stopped eating. So that restricted eating, I mean, she was, I think, about 33 pounds. She was just a tiny little thing anyway. And she started losing weight. By this point in time, at least we had a doctor at that point that I could call and say, I think we're doing this again. And he got her in right away. But that was really scary to just see somebody just start to deteriorate like that. She just couldn't make herself eat any of the food. So we did treatment for them, and I'll talk about that in a minute. I want to talk a little bit, though, about Lola here, our most recent bout of this, which sadly we are still going through. So When the kids are in, I guess this would have been like fourth, fifth, sixth grade when they had this the first time. Um, it looks a lot different, at least in our case, it looked a lot different than what it looks like in a 16-year-old. 16-year-olds are, they're smart, they're driving, able, they're going through so many things anyway. I don't think she realized that the racing thoughts and the anxiety and things she was having was much more than being a 16-year-old girl, right? Um, we were worried there was some eating disorder, but again, 16-year-old girl, right? We were looking some treatment for that, but I really didn't put that together with PANS PANDAS. Hindsight is 2020, but at the time, it seemed more just high school sort of stuff. She was also on SSRI, and she really got into a dark place, I guess, with self-harm, which I found out after the fact, but she ended up having some suicidal ideation and a suicide attempt. So we are very, very, very lucky that she is still here. Um, and this is still going on. She's in some treatment right now, and we're hopefully going to be getting her back soon. So you can go to the next slide. Let's see, where are we headed next? So just the different ages, different signs. And then we've got, I want to talk about a little bit about just getting diagnosed. I talked about how it took us so long to find anyone. And quite honestly, I can't tell you how many doctors looked us straight in the face and told us we were bad parents. We were enabling them not going to school. We needed to be stricter. We needed oh my gosh, we needed an organic diet. We needed to cut out sugar. We needed, the list was, we tried all of it, anything anybody would recommend. With my oldest, we ended up being seen by psychiatric. It took probably 9 months to get in there. And they said it was just depression, anxiety, and put her on an SSRI. And even for her at that age with the SSRI, she told me that she was having these intrusive suicidal thoughts. The way we ended up finally getting an official diagnosis, even though we had our suspicions what it was, it's very, very lucky. I was not working much because I was going to school with our oldest, trying to get her to be at school just a little bit. And then I'd try to get back up to the office when I could. And anyway, I had a meeting one day, and a woman came in, and she was so lovely, but just looked like she had been through the ringer. And she had just moved to the area. And so after our meeting, I had her come to my office and was going to give her, I don't know, do you need a hairstylist? Where are you going for groceries? Those sorts of things. And she started telling me about her daughter who had been very sick and just had this treatment out in DC. And that, some of the things that had been happening after treatment. And long story short, her daughter had just had IVIG for pandas, which I couldn't even believe I was talking to someone who had that. I had been looking at this stuff for months. There was a doctor's office I would call all the time, but get the answering machine. And I don't know, I wasn't sure if it was real or not. And she encouraged me to call and just leave a message. And I ended up doing that. And within probably the month, we were being seen and getting treated. Without that interaction, though, I don't know where we would have ended up or how we would have gotten there. And I feel like so many people with this, it's really just lucky who they talk to and who you find to try to get some help for this. Anyway, a little advice from the trenches here. This is a really hard thing for your whole family. So that picture I showed you before when Lola was just wee little girl, she was 3 when our oldest got this. Her whole life has been dealing with somebody having this in some form or another. Um, it's just it makes me sad when I look back and think, my God, that's been 14 years and we're still doing this. That's actually crazy. But a couple of things I wish I would have known early on, especially with little kids. It's a little different now with bigger kids, and maybe in a few more years I'll have more advice, but I'm still just trying to figure it out. But when your kids are little and in a flare, fighting with them, I swear it doesn't help. It makes everything so much worse. And you're not fighting with them, you're fighting with the inflammation in their brain. This isn't your kid anymore. I mean, it is, but they're not wanting to do these things. They're not wanting to act the way they're acting. And after my first one, when I got to the second and third and they couldn't go to school, I mean, we already had the appointment lined up for IVIG, and I was like, great, we're not going to go to school today. Life was so much easier. Oh my gosh. Just to not have all that fighting and to cause them and like to put them in those positions where it's their worst fears, that separation anxiety, that fear something terrible is going to happen to their mom or their dad or their family when they're away is so real to them. So that made things a lot easier. The other thing that is shocking to me is that when our kids with this are at their absolute worst, like just the worst, they don't remember it. At least in my situation, my kids do not remember the hardest times that they had. As parents, oh my gosh, that's still with me. But as the kids, if you just keep loving them and keep them safe, they're going to hopefully remember that feeling of you keeping them safe, but they're not going to remember how bad that they really felt. Another thing is people are going to judge. This is a really, really lonely thing to have and to deal with. It's a lot different. Not that I wish we'd have a kid in the hospital or anything, but I feel like if your kid is sick and you've got a diagnosis and they're in the hospital, kind of people come together and they'll help. And this is from the outside. People think like you're really bad parents. At least for us, I felt a lot of that. And early on, even from people in our family, there was a lot of judgment and how can you let them get away with that or talk to you like that or different things. But just know, you know your kids, you know who they are. And truly, your kids, they don't want to be doing this. They don't want to be acting like this. So just give yourself grace. We had to isolate and hunker down pretty good. Part of it, you can't really predict when there's going to be a flare, if you're going to be able to meet somebody for dinner or not. And so I felt like our social circle got really, really, really small because you're just sort of on call all the time. And, Murphy's Law, you plan something, somebody's not going to be able to go do it. And that's okay. And then the last thing, and this is just coming as a friend for anybody who has this. This isn't official medical advice by any means. I was really scared of IVIG. I didn't really understand what it was or what it meant. But what I learned and how it was presented, it really felt like if it worked, what a blessing. And if it didn't, we weren't going to be hurting the kids at all. So it took a lot of that scare and risk out of the way for us. And I wish I would have just gotten to that sooner. We could have avoided a lot of pain for a lot of time. Last thing I just want to touch on briefly here is, you can go to the next slide, please. The last thing I want to touch on is that your kids can get better. I can't even believe it, but these are my two oldest ones, and I will have my youngest one. She could be on here too because she's getting much better. But the main thing is these two kids are actually in college. You guys, I had to go to school with them for the oldest for a year and a half. I didn't know if she'd be able to go to sixth or seventh grade without me. And she's in a senior at Tulane, graduating college, going to law school, moving to New York. Like, her life is great. Here's my middle son. He's a freshman at Auburn, literally having the best time of his life. They're so good. They are so, so, so good. So there is hope. But after this, as parents and maybe as your whole family, it's not a bad idea to really get some therapy. You've been through so, so, so much. And these traumas, there's big T traumas and little T traumas. And I know that people call this little T, but I'm telling you, it feels like big T trauma. And take care of yourself, work on your marriage, work with your family, and just get everybody together. Because as you get through this, you're so lucky to still have each other and to be, I guess, getting back on with life. Just one thing, you can see that this runs in families. So if you have it in one kid, be on alert. Any of these different symptoms, it's not going to look the same in other kids. Be on alert though, because it could happen. I found out that now as the kids are getting older, and as our doctor has worked with people that are getting older, he said when these kids, when they become parents or have kids that go to preschool or kindergarten, they can have relapses or a new flare or have it again. I don't know the correct terminology, but I feel like I've got to be on the lookout for that, and we're all going to be hypervigilant to keep watching for that. But in the meanwhile, just enjoy the kids while you have them and keep working hard so that they can get better. I think that's all I have. I'm not sure if I don't think I have another slide. So, yep, that's it. So thank you. And I'm going to hand it back over to Christy, and she'll have time for a Q&A if anyone has any questions.
Thank you so much, Gwen, for sharing such a personal account of your family. And I think what many families are going through, and I know that that resonates with many. I think that we're going to forego the questions, and we will try to answer them in an upcoming newsletter. But I just want to thank our speakers. Again, Gwen, that was amazing. And I think really the Pandas Pans piece, this really highlights why this research is so important to be completed. And being able to have publications that help clinicians and help families be able to kind of sort through these types of things. It's a long and scary process, and there are a lot of things that do go wrong. But I do want to thank Melanie and Dr. Fitzgerald and Gwen for this incredible presentation today. And we are really trying to get more pediatric patients in, and that's been said several times today, but be sure to go to our website. We do have a separate website for Unhide, and you can see some of the current research that we have going on, other things that you can participate on. If you know families that are going through these types of things, please let them know. And we are a 501(c)(3), so if you are able to contribute, please go to our website. It's braininflammation.org/give. There's a lot of information on there to read through. We do partner with other advocacy groups. And I know there was a question in there, do we have a list of doctors that we recommend? And we partner with advocacy groups and let them handle those pieces. And as we grow that base, we'll be able to recommend different advocacy groups to help with that piece of it. So, we're so proud to have collaborated with our presenters today, and we hope that you'll be able to join us again next month. Make sure to follow our social media accounts. We have some great research updates and to learn more about us. But we look forward to seeing you next month. Thank you so much for joining us.